Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
So our first question for you today is from Stacy, and Stacy submitted this question on the Mingle Health website. So thank you, Stacy. Stacy says, is there a way to move patients from one ACO to another without having to gain claims attribution? We have two ACOs, and we want to move patients from one to the other without losing data.
Great question, Stacy. There are three things that can move patient attribution from one ACO to another. Which ones you can take advantage of depends on your circumstances. Now, attribution rules can vary a little by contractual choices you make in any program you join, and more so between different CMMI programs. CMMI, of course, is the Center for Medicare and Medicaid Innovation. In general, there are three dynamics in play. One, there can be prospective attribution. In prospective attribution, the highest priority is patient choice. Medicare beneficiaries can log into My Medicare and designate the provider of their choice as their primary care provider. This is the highest priority attribution step in the attribution analysis. Patients are attributed to the TIN practice in which their provider of choice practices. Now, let me just take a moment on TIN practice. TIN is tax ID number. Medicare defines a distinct practice by its tax ID number. So you can have one tax ID number covering practices that are in multiple locations, or even two practices in one location, each having different TINs. But to remember, the TIN is always part of that identification of a practice, even in the ACO level. ACO participants in MSSP ACOs anyway, that's the Medicare Shared Savings Program, join as a whole TIN at a time. Now, the secondary priority, or if it's only retrospective attribution, the first priority is assessment of the plurality of care from a primary care provider. Medicare counts encounters or visits. I'm using the terms interchangeably here. For primary care services provided by a primary care provider. Now, services considered to be primary care services include most or all of the E&M codes in the list of billable CPT or HCPCS HCPCS codes. This list is updated periodically in the rulemaking process, and you can find the current list in the rules or on some of Medicare's publications. Specialties considered to be primary care specialties include family practice, internal medicine, geriatric medicine, and general practice and their subspecialties. Pediatrics is part of that mix, but you don't get many pediatric Medicare patients. Now, attribution based on primary care services is based on plurality of care. Plurality means that the TIN the tax ID number practice, where primary care providers provided more primary care services than in any other practice. So that's the definition of plurality. So now the third priority, used only if there is no primary care provider who provided at least one primary care visit. Patients can be attributed to other specialists who are not generally considered primary care providers if they billed for at least one primary care type visit. And if there are multiple specialists who provide the primary care type visits, then it'll go to the one with the highest plurality of care. That's the greatest number of visits. Now, with that background in mind, let's specifically address Stacy's questions about how to move patients from one ACO to another. If the patients are moving because their practice, that tax ID number practice, has left one ACO and joined another, their attributed patients come with them. There's no realignment required. And that would be the most common reason why you'd want to move patients from one ACO to another. You generally can't move them if the provider isn't going with them, unless you convince them to see patients in the new or providers in the new ACO. Now, if one or more providers have left a tax ID number practice participating in one ACO and joined a different TIN practice aligned with a different ACO, that provider's patients will not attribute to the new practice in the new ACO until an attribution action occurs. That is, they have enough new visits with their old provider in the new practice that the attribution calculation moves them. Now, prospectively, you can go to each patient or as they visit you, or you can call them, you can suggest or even help them log into mymedicare.com and select their primary care provider as their PCP. So they can, in the practice of your choice, in the ACO of your choice. Or retrospectively, you have to wait until they're realigned when they have enough visits with the provider in the new practice and the new ACO, and they have enough visits to establish a new plurality of care. Now, I'm not aware of any bulk action or shortcut to get it done. Now, if I've not answered your question, Stacy, give me more of the particulars of the challenge you're facing, why you're moving patients, how are you moving patients, what's happening to the doctors that have been taking care of them. I'll try to be more specific. But thanks for the interesting question.
Yeah, thank you, Stacy. And our next question for you today, Dr. Mingle, is actually a YouTube comment from Steve. So thank you, Steve, for the excellent comment. So Steve says, it might be important to note the APM bonuses larger than those potentially provided by traditional MIPS are now going away. We used to get a 5% lump sum bonus on Medicare payments for earning qualified participant, that is QP, status in an alternative payment model. The bonus is down to 3.5% in 2025 and is based on 2023 APM attribution and QP status. It will go down to 1.88% in 2026 based on 2024 attribution and QP status. And starting in 2027, the incentive will only be a 0.75% boost to the conversion factor on the physician fee schedule. It might be advantageous to be a partial QP if possible and submit traditional MIPS.
Thanks, Steve, for the observation. I like how you think. You found strategic value in partial QP status. Now, I think the take home from this is not to fear partial QP or even non-QP status. There may be some advantages. I stop short, though, of recommending that you seek it. I don't think it's as easy as you'd like it to be to avoid QP status. QP status is indirectly a measure of patient engagement, which is pivotal to controlling healthcare costs, to access the gains in whatever alternative payment model you're in. And MIPS incentives are not as clearly better or easier to access than QP incentives. Now, before I explain those points, for those of you for whom qualified participant status is a new concept or still confusing, let me make an attempt to explain it. And when I talk about our alternative payment models, I'll talk about the Medicare Shared Savings Program because it is by far the most commonly used alternative payment model. But the principles I discuss are widely applicable to all or any APM. Every APM has a reward for healthcare cost savings, which is why, that reward is why you as a group are participating in the APM. Qualified status is granted to participants in an advanced payment model, that is, any model through Medicare's Center for Medicare and Medicaid Innovation. There's a threshold that you must hit to be a QP and a lower threshold to be a partial QP. And if you don't hit either threshold, you're not a QP. Medicare measures, to establish this status, Medicare measures your volume of Medicare patients. First, they take account of the unique Medicare patients you saw in a year. And second, they total the allowable charges you submitted for your patients in a year. Now, Medicare compares those numbers to the subset of those patients who become attributed to your ACO. There's a threshold percentage. Now, Medicare has been slowly increasing that threshold. For the 2025 performance year, the threshold is 50% of your allowable charges or 35% of your count of unique patients. If you achieve either of those thresholds for 2025, you are considered a qualified participant or a QP for 2025. Now, there are lower thresholds to be a partial QP and also lower thresholds, different thresholds for being a QP or partial QP in an all-payer model, but we won't go into that. For partial QP status in 2025, it's not 50, but it's 40% of allowable charges. And on unique patients, it's not 35, but 25% of your unique patients. Now, for any particular year of participation in an alternative payment model, you can be a qualified participant, a partially qualified participant, or neither. That is a non-qualified, non-QP. Now, and what do those statuses mean? If you're a QP, if you're a qualified participant, you have no MIPS liability. You won't get credit for a MIPS submission even if you make one. If you're a partial QP, you can choose whether or not you'll participate in MIPS. Ideally, you will submit MIPS if you expect to score well and earn an incentive, and you'll not submit if you think there will be a negative incentive. If you're a non-QP, you're liable for MIPS and will receive whatever MIPS incentive you earn. You don't have a choice. Now, whether QP or not, all participants will benefit from whatever reward your APM model applies for cost savings. Of course, the distribution of those rewards are subject to the terms of the participation agreement you have with your ACO. So, with that in mind, let's go back to the points I made about non-QP status. Now, it's not easy to avoid QP status. So if you find a strategic advantage to being a non-QP, it's going to be a hard thing to do. To illustrate that, let me go back to the most recent year that Medicare's published these statistics. That most recent year now is 2022. So in 2022, there are 420,000 advanced APM participants in the United States. 386,000 of them, or 92% of them, achieved QP status. 34,000, that's only 8% of them, were non-QPs. And only 300, that's less than a percent, that's about 0.1%, were partial QPs. Knowing the dynamics, I suspect that virtually all primary care providers become QPs. For those who don't, there's likely something very unusual about their practice. Maybe they have a set of non-primary care services they're providing to patients, maybe even on a referral basis, or they're unpopular enough that patients don't come back to them, which is necessary to end up being attributed. The dynamics of primary care practices and patients' relationship to their primary care doctors nearly assure that those patients will be attributed to those primary care providers. Now, I suspect that most partial QPs and non-QPs are in specialty practices, determined not so much by patient returns or patient engagement, but by their referral network. If you predominantly get your referrals from within the ACO, you'll more likely be a qualified participant. If you have a broader pool of referral sources, so it's only a small percentage lower than the threshold that come from within your ACO, you're likely to be a partial or a non-QP. Now, my second point is that it's not good for the ACO if you're deliberately avoiding QP status. One of the only ways to do that is to avoid seeing patients on a recurring basis or being unpopular enough that people don't come back, and encouraging people, therefore, not to be engaged. But if the ACO doesn't have engaged patients, it has no influence to promote cost reduction. And attribution, I would say, is a measure of engagement. If you're a primary care provider, low attribution is a bad sign. Now, my final point is that higher incentives available in MIPS are not assured by any means. In advanced APM, all qualified participants earn the incentive. That was true when it was 5%. It will continue to be true when it changes to 0.75% on the conversion factor. In the new model, a boost in the conversion factor means that all payments for Medicare services are higher, not just Medicare reimbursements, but out-of-pocket expenses for the patient. It means that in comparison to MIPS, the APM incentive is going to effectively be closer to 1% than just 0.75%. MIPS incentives are revenue neutral to CMS. They collect as much in negative incentives as they distribute in positive. So the average incentive of MIPS is designed to be zero. So there isn't an assurance that if you go for a MIPS incentive, you actually get one. On the other hand, on the advanced APM, everyone who becomes a QP gets the incentive. It's not withheld from anyone. It is that number. There's no graduating level, and there's no negative incentive if you don't become a QP. So if you end up participating in MIPS as an advanced APM participant, you're not likely to get into big negative incentives. I mean, the maximum negative incentive is minus 9%. And you're unlikely to get that. Even if you don't make an additional submission, your APM's quality submission, at least in the MSSP, that is the Medicare Insurance Savings Program, will count as your quality score. So you'll get the same quality score that as your ACO received, unless you make a different submission that has a higher score, in which case you'll get the highest of the scores submitted in your behalf. You'll earn 100% of your practice improvement points as long as you make any submission at all, as all APM participants do. You're not going to get a score for cost. Cost incentives for APM participants, even if they're not qualified participants, are built into the payment model. They don't come from the incentive. So you'll be forgiven from cost, even if you're subject to MIPS. And there'll be a CERT, the use of certified EHR score. And you'll either generate a score through your work with the APM, or you'll have an exception. So you'll either be forgiven from it or have a score. So overall, you're going to have an aggregate score that may land you in the negative incentive range, but it won't be dreadfully low in the negative incentive range. And the most important point being that it's not uniformly positive, as is the QP incentive. So thanks for this stimulating exercise, Steve. Great comment, great observation.
Yeah, thank you, Steve, for the great YouTube comment. Our next question for you today, Dr. Mingle, comes from Corinne in the form of feedback on a recent blog post, an Ask Dr. Mingle blog post on minglehealth.com. So Corinne says, thank you for sharing this blog on self-submission of Medicare CQMs as an ACO. I wanted to follow up on the answer to the first question Dr. Mingle mentioned, that to submit Medicare CQMs, we must be a Medicare qualified registry, and the submission requires a valid registry identifier while following the process outlined in Medicare's Qualified Registry Self-Nomination Toolkit. However, I wasn't able to locate the specific CMS documents that state this requirement. Could you clarify where I can find the official CMS rules or website that confirm that we must be a qualified registry to submit Medicare CQMs?
Wow, thanks for your challenge to my answer. It sent me to the QPP resource library and to the Electronic Code of Federal Regulations, that is ecfr.gov, to confirm the facts. After reviewing, I think that you're likely correct, that you do not need to have qualified registry status in order to submit your own quality measures. When Medicare launched quality reporting back in 2007 in the physician quality reporting system, it was explicitly clear that anyone who submitted quality measures had to be qualified as a registry. I built my first registry for and within the community health system in which I worked at the time. Sometime in the last 10 years, the rules quietly changed. It's not as explicit as I'd like to see it. It is explicit that if you're a third-party intermediary, that is us. We're not a practice. We make quality submission, and we do the analytics and submit the numbers for our clients. If you are a third-party intermediary, you have to be qualified by Medicare as a registry in order to submit quality measures. Implicit in the way they've written it is the expectation if you do it yourself, you're not subject to the rules and the requirements of qualified registries. Now, this could have been a deliberate change that I've missed, despite the fact I read the proposed rules and the final rules every year since 2008. It could just be a drift in the language as institutional knowledge ages out of Medicare. That is, people rewriting the rules this year, cleaning things up, modernizing them, don't really remember the workflows, the rationale, the rules as they were practiced from previous years. I think you can make your own submission. I'd be more confident if I knew of anyone who has successfully made that kind of a submission for their organization without achieving qualified registry status. So with this answer, I'm asking all of you, have you or anyone you know made a quality submission of MIPS CQMs or Medicare CQMs without achieving and maintaining qualified registry status? I know you can do it with ECQMs, but I'm interested in your experience with MIPS CQMs or Medicare CQMs. Thanks, Corinne, for passing that feedback on to me.
Yeah, thank you, Corinne. And our final question for you today, Dr. Mingle, is from David. David asks, how is the current turmoil in the federal government going to affect the quality payment program?
Oh, great question, David. I wish I knew for sure. We are certainly living in uncertain times when it comes to federal programs and enforcement of federal rules. Now, whether you are a MIPS participant or a participant in one of the alternative payment models of the Center for Medicare and Medicaid Innovation, that is CMMI, there have already been changes and there may yet be more. It's a volatile situation. Things can change quickly. This is what is happening and how I see things today, but it could be different tomorrow. Medicare continues to function. It's paying for care as it normally does. It's running the merit-based incentive payment system as it has in recent years, and it's running the Medicare Shared Savings Program. All programs are fully operational. We're well into the 2025 performance year already, past the first quarter. Now, Medicare has canceled a couple mandatory monthly meetings they've held for the last 18 years to manage their qualified registries. So for the first time, they called those off. CMMI has brought 4 programs to early closure. The Maryland Total Cost of Care model is closing at the end of 2025, as is the Primary Care First model, the End-Stage Renal Disease Treatment Choices model, and the Making Care Primary model. Now, it's hard to be sure what's going to be left and what's going to be required of us when 2025 comes to a close and we enter the submission season. That is the first quarter of 2026 for our 2025 data. Now, I'm not expecting to see any of the core programs change. Medicare is the world's biggest healthcare insurance program, and the people in the United States depend on it. Damage to the program, I think, would amount to political suicide. Now, I include in that assessment that Medicare Part B, the physician payment program, Medicare Part A, the hospital payment program, Medicare Part D, the drug payment program, Medicare Advantage, and the merit-based incentive payment program and the Medicare Shared Savings Program will all continue to function. You should plan to continue business as usual, provide care, generate bills, participate in quality assessment, quality reporting, advance the use of your certified electronic health record technology. Don't expect relaxation of the requirements. I think we should expect a general slowdown of service and of programmatic evolution. For MSSP users, that's a Medicare Shared Savings Program, the web interface is gone after this 2024 data submission window is over. And I don't expect Medicare to have the resources or the will to revive it. So you will be going to eCQMs, Medicare CQMs, or MIPS CQMs for the next couple of years for your submissions. I'm expecting less activity than usual in the proposed and final rules for the physician fee schedule. I don't think there will be as many changes. I don't think there's going to be as many people working on the proposed and the final rules and able to curate those changes. I'm expecting slowdowns for the programmatic evolutions they've already posed, like moving to MIPS value pathways or generating and opening new CMMI APM models. I'm expecting delays in service and attention. So the QPP help desk may not be as responsive. Individual attention to extreme and unusual circumstances applications might be slower. Now, it could be that they will refuse more, or it could be they'll rubber stamp more to keep their workload down. It's probably not a good time to start participating in a new program, that is building a new ACO, participating in a new CMMI program. Day to day, the safest approach will be to expect no change to your requirements. Even if anything does change, we've seen enough volatility that an announced change one day might be canceled the next. So my advice, continue business as usual. Provide the great care you always provide to your patients. Continue to collect and save your data. Continue to improve on your EHR functionality. Plan to continue compliance with submissions. Don't trust changes until it's too late for Medicare or their federal overseers to reverse them. And if you're in the MSSP, the Medicare Shared Savings Program, plan to switch to eCQMs, MIPS CQMs, or Medicare CQMs. You will not have the web interface to fall back on. Good luck managing all these changes with the rest of us.
Thank you for the excellent question, David. Thank you to Stacy, Steve, and Corinne as well for the questions. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. And thanks to all of you for your great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct me or supplement my answers. Share your experience, ask your questions. We can be smarter together.